Good afternoon. Welcome to the fourth and final session of Pushpagiri webinar series, Being in Charge, a Guide to Management in Primary Healthcare. Organized as part of our annual CME program, our webinar series started on November 19 with our first session by Dr. Anish Yes, as he gave us a picture of primary healthcare and its components. Our second session on health program implementation and challenges on November 26th was taken by Dr. Rashmi MS, Deputy DM of Kerala's Pathanamthitta district. And our third session, last Thursday, was on material management with Dr. Sinia Nujum. It is with great pleasure that we welcome you to today's session, where we will be discussing intersectoral collaboration with Dr. Indu PS, Professor and HOD of Community Medicine at Government Medical College, Toronto. We remind you to please leave your questions and doubts in the comment box, and we will address them at the end of the session. Dr. Indu is the coordinator of Kerala State Prevention of Epidemic and Infectious Disease Cell and is also a member of State Rapid Response Team. She is a member of Expert Panel of Administrative Reforms Committee on Sustainable Development. Dr. Indu has served as Principal Investigator in several research projects, including Government of Kerala WHO Dengue Study, which is a collaborative research project jointly undertaken by the Government of Kerala and WHO Headquarters Geneva for a period of 2017 to 2020. Dr. Indu is also a PhD guide under the Kerala University of Health Sciences. She has numerous degrees in various fields, including public health, clinical epidemiology, and psychiatry. Ma'am, it's a privilege to welcome you to our final session. Over to you, ma'am.
Hello, Ellen.
Yes, ma'am.
Yeah, actually, ചെയ്യാം അല്ലേ? Okay. Okay. Yeah. Good afternoon. Congratulations to the Department of Community Medicine, Pushpagiri Institute of Research and Medical Sciences, Thiruvalla, for organizing this series of lectures in relation to public health. Thank you, Ellen and team, and the entire organizing committee for inviting us to participate in the series. Could you see, can you see the changed slides, Ellen?
Yes, ma'am. Yes, ma'am.
Okay. So, collaboration at primary level, reality and challenges. COVID-19 has changed everything. The way we think, the way we live, the way we teach, where we understand the dynamics, not only in primary care and public health, but in every walk of life. The economy, the social living, the education, everywhere. It's also an opportunity to uncover certain blind spots in health systems all over the world. Some of us might have read the Lancet article on policy this week by Arush Lal et al. Fragmented health systems in COVID-19, rectifying the misalignment between global health security and universal health coverage. This discusses the ways in which vertical systems, vertical program financing, and fragmental approaches in governance of health in various countries reflected in the ways those countries responded to the COVID-19 pandemic. Basically, the article compares 3 types of health system. We are all like in community medicine, there's a section on international health. So in this 1 hour, I would briefly go through some of the areas in relation to collaboration in public health and primary care in the international scenario with examples from certain countries and then Indian and the Kerala context. Back to the Lancet article, it compares 3 types of health systems of countries. 1, the set of countries which invest in global health security. As we all know, global health security was in news not only because of health related, but the nuclear threats, bioterrorism, several other reasons. If we look at the global health security action agenda, there's an index also, the GHS index, the Global Health Security Index. If we go through the CDC website, I think GHS itself has a website. And if you go through the indices, they released by 2019, United States of America stands first. Second is United Kingdom. I think India is in 54th position also. Australia is in 4th position, etc. So that is global health security. And the second set of countries are those who invest in universal health coverage. And third, integrated investments in both global health security and universal health coverage. As we said, it results in silos in financing, vertical funding streams towards, single disease categories, independence of tertiary care from primary care, differences in domestic health priorities and global health priorities. And as we know, the global health security is centered around the international health regulations on prevention, detection, responding to public health threats, particularly like people and societies worldwide from, it's mostly communicable disease sets. But on the other hand, the universal health coverage and what are the basic core competencies in public health, though we say global health security is focusing on prevention, protecting the countries from communicable disease, what are the core competencies of public health which guides the development of the global health security agenda? Can someone speak? Ellen, I don't know the names of participants. I think I'm in a view where it's.
Ma'am, you can click on that participants link. There's a small button below. You can see the
okay. But I thought I'll go to the slide share because, okay. Yeah, but then is somebody from Trivandrum? Ellen? Because I'll be knowing their names. Anyone? Sucharita? What are the core competencies? Sucharita, will you introduce yourselves? Raktin? Jitin? Anisha? Anisha, are you there? Bhavani, Divya. I think there are 2 Divyas. Gatha. Gatha is from Trivandrum. Yeah. Gatha, mention one core competency in public health. Alan, am I audible?
Yes, ma'am. You're audible. Yes, ma'am.
Okay. Alan, yeah. You tell. At least just some core competency in public health. We have been learning community medicine and public health for quite some time. One competency that, or a core capacity of public health. In communicable disease context, yeah, every district wants residents and faculty and specialists in community medicine. What is our competency that they're looking for? Like when there is an outbreak, they don't call cardiologists, physicians, and others to the district team, but always community medicine specialists are invited. Why is it so? What is that core capacity that makes us? Yes, Ellen?
Analytical skill, policy development.
Okay.
Is that
Okay, then?
Communication skills.
Okay, Gada? Gada was about to say something.
Ma'am, public health administration.
Okay. All these are core. Very good, Ellen, Gada. Thank you for participation. Otherwise, it will be rather boring. That is why keep it interactive. Surveillance, risk communication, coordination, as Gada said, public administration, another very important core capacity in public health. See, though we say global health security is not primarily primary health and primary care, we see the basic capacities of public health, core competencies of public health in every subdivision of community medicine, surveillance, risk communication, etc. So, but naturally, when we say GHS, what are the prospects of GHS? That is not something that is closely related to primary care. The second set of countries are those who are investing on universal healthcare. As we know, it enables primary healthcare systems and improves the accessibility. So that is about services. So when we use the term universal health coverage, there is a usual implication of financing, but that is, as we know, that is much more than that. It's giving high quality, effective services in all the sub areas of healthcare. So WHO highly prioritize both these aspects in primary care and public health. And the next few minutes, let's have a discussion on some of the models on collaboration. Basically, what is the difference between some other, if you look at in undergraduate teaching, we tell them what are the 4 pillars of primary health care. What are they? There is coordination, intersectoral coordination, right? Equitable distribution, appropriate technology, then intersectoral. So what is it? What is the difference between coordination and collaboration? Are they related or similar? Anisha, is there any similarity or a difference? Just to elicit a discussion. Sumita? Dr. Sumita Sharma? Yeah. We know in intersectoral coordination, is there a difference? See, what is collaboration? Collaboration is always working together, right? In collaboration, there is a common goal. We'll go through these examples. For example, if there is a scheme or a project where 2 departments, 2 agencies work together, it is working together with a common goal. In coordination, like departments can work together, but each single user has their own priority areas. Well, this discussion, we are focusing on collaboration, right? So let's see some of the international examples. This is a module. Some of you might have read this. Most of the examples are from European region of WHO. I'll quickly go through some of the recommendations to enhance collaboration. But before that, is there a volunteer who will tell us about some of their experiences in collaboration in primary care? Someone other than Ellen and Gada? Parayamo. നമ്മളുടെ PHC posting, someone who's, I think there are other, from other states, there might be participants who do not understand Malayalam, right? So any example in which you were involved where collaboration happened in primary care? Please volunteer, please unmute and speak. Gada ഒരു എക്സാമ്പിൾ പറയുന്നോ? അനീഷ? Well, so to enhance collaboration, see, there is something called inertia, right? We all work, whether it be primary care, tertiary care, teaching or research, right? Something which we are tuned to. To collaborate, we need to have a rather broader, accommodative, goal-oriented kind of mindset, which enhances satisfaction in the agencies or institutions where they work. We'll come to some of those details later. These 10 recommendations are theory, and that is all adapted from the WHO module on this. And then if there are different agencies or participants or departments or institutions in the collaboration, we have to define and sell goals for all the parties. And then, you know, we can work on our own. For example, see, we are running a preventive clinic. We can run it on our own. But to have a program jointly run, preventive clinic, we treat cases with dog bite. It's our own area. But then we need to have a different kind of professional capacity to work on a rabies elimination or eradication program in a panchayat, because we'll be working with animal husbandry, we'll be working with the LSDD or other stakeholders. And third is a flexible legal and structural framework for the program at the macro or micro levels. For example, what is REPLACE? REPLAC. REPLACE is a program by the WHO for I request someone to speak. I know all of you know and understand, but then, okay. It's for reduction of trans fatty acids. So in trans fatty acids, who are the stakeholders? It needs to be a collaborative effort. It may not be much at the primary care level, right? The industry-driven trans fat, the food industry, the regulators, you know, from the person or all of us who eat food containing trans fat, to the manufacturer, to it's a complex network with several stakeholders. For all these stakeholders to work together, we might need a legal and structural framework. Definitely, trust is another very important, you know, requirement, and collaborative practice, valued professional competency, develop national policy goals. Of course, in vertical collaboration and horizontal collaboration, you know, vertical collaboration should have a national policy goals, etc., and the process has to be clear, and structural incentives across the program goals. Then organizational synapses, where in which all areas we will converge through technology, IT has revolutionized the way collaborations happen, and as in any public health activity, we need monitoring and evaluation. This was rather a dry theory on the recommendations for collaborations. And now, why do we collaborate in primary care? Will someone volunteer to speak 1 or 2 sentences? Alan? Why do we need collaboration in primary care?
Health setup alone cannot work.
Pardon? In which area?
I mean, administration and
Okay. Can you be more, down to earth? Which are the areas? We are at the primary care level. Yes. One.
I mean,
Yes.
influx of materials and even material we need.
Okay.
Infrastructure.
Okay. For building infrastructure, etc., we seek funding from elsewhere. Okay, that's one. Any other area where collaboration can happen in primary care? Anisha? Gata? There is. What are the public health priorities for Kerala? Yes, Gada.
Vaccination.
Okay, immunization is one area. What are the major public health priorities for Kerala in India? We'll talk about in Indian context or Kerala context. Priority 1, 2, 3. Something where the action can be initiated at the primary care level. Think of the primary health centers you have been working. You worked in Alapi, now you work in Pangapara, which is rather an urban setting, and Vakam, which is a rural setting. Think about the priority areas where we can collaborate. Raktim? Okay. I think he is unmuted. Please speak. Okay. Several areas. Like, as we said, collaboration is about working together to have a common goal. It is beyond, it is a little different from more than what coordination means. Coordination means, the primary health center works. It has its own mandates. The water authority works. The food safety works. Schools function, right? We coordinate the activities in certain areas. For example, see, there is an iron folic acid control, program, right? So weekly program, we go there, we take a class, we distribute this. So it is more of a coordination. What is collaboration? So I'll go through some examples from other countries. This is one physical activity prescription, a physical activity on prescription, right? Usually we give, what do we give usually prescription for? A patient comes with fever, paracetamol is given. Someone comes to check their blood pressure, we give maybe a calcium channel blocker, and the patient gets it from pharmacy. So this I think is a Swedish program. GPs, general practitioners, will identify patients with a sedentary lifestyle with increased risk of non-communicable disease. And then there is a 4-month behavioral intervention. It's a prescription for a 4-month behavioral intervention. But will the GP be able to totally, if it is a drug, the prescription can be given, the drug can be dispensed from the pharmacy, right? So, but here we need to have something else, some other agency, someone who has a different competency, skill, so that the behavioral intervention gets sustained, right? So that prescription gets implemented by a collaborating agency which implements the physical activity program. See, there are several, I think in Kerala also some of the or many of the primary health centers and family health centers have set up gym. In many other countries where lifestyle modifications, modification interventions begin within the clinical setting itself, you will see this kinds of equipments and instruments. And I think in some of the some countries, every hospital, every healthcare setting, for that matter, most of the workplaces also will have a similar. This was a photo taken by us when we visited one such institutions. Like that is common there. And now another example is Danish Healthy Cities Network. See, there are several such initiatives. So the municipalities take part in the professional public health network, strengthen health promotion, disease prevention at the municipality level by bringing together professionals and politicians to exchange experiences and learn. See, this is different from, this is the lifestyle clinic, but this is not only about, see, Healthy Cities Clinic is not only about establishing a clinic for lifestyle, because in lifestyle clinics, you may not really go there with a disease, but then you may go there with several, like you would like to reduce your weight without any indication for a clinical consultation. You go there and have a healthy lifestyle. But then in a healthy city networks, for example, think of healthy Thiruvalla or healthy Trivandrum, healthy Kottayam, healthy Calicut, healthy Mumbai city campaign, right? So several components. Think about at least one component, something that enhances physical activity. We need to have pedestrian paths where people can run or walk at any point of time. Then park or grounds where see, every 1 or 2 or 3 kilometers, we need spaces for people to come out in the morning or evening and walk, so that walking and running becomes a habit and lifestyle of our toddlers, children, adolescents, youth. So this kind of collaboration in primary care is not about prescribing drugs and early identification alone. It is about promotive and preventive care as well. A third example is Italy National Immunization Plan. 2 years ago, we had our MR campaign, the measles rubella immunization campaign, and we had come across with resistances from certain groups. And we were trying several solutions for that, mostly through campaign and education. What Italy tried was that the collaboration was with the education department. Education and health joined together. So what was the common goal? Every child has to be immunized before school entry. So the education has a part, health has a part. What is the Department of Health's role in that? Naturally, we have to find out children who have been, we have to vaccinate them, make sure that every child is vaccinated. What is the role of the education department? They have made it mandatory, and every child who gets entry needs a certificate that from the health that they have been vaccinated. The law also comes. Several other examples, the behavioral intervention part. Another example is the Amsterdam Healthy Weight Program on tackling childhood obesity. I think among the participants, is anyone familiar with a program where childhood obesity is targeted? We have some panchayats working on enhancing physical activity and improving diet, but then is there someone who is familiar with any program, collaborative work where childhood obesity prevention is targeted? I request someone to speak. Ellen, you can also call out names. Okay, shall I continue? Am I audible?
Yes, ma'am, you are audible, ma'am. Yes.
Okay. Yeah. Who are the others from Pushpagiri other than Ellen? Sonu is there?
Yes, ma'am, Sonu is here.
Sonu? Dr. Sonu Soman?
Yes, ma'am.
Yeah. Sonu ഓർക്കുന്നുണ്ടോ Sonu?
Yes, ma'am.
Okay. Sonu, ഇതുപോലെ ഈ കുട്ടികളുടെ ഒബീസിറ്റി പ്രിവെന്റ് ചെയ്യുന്ന എന്തെങ്കിലും ഒരു കൊളാബറേറ്റീവ് വർക്ക് കേട്ടിട്ടുണ്ടോ? Suppose you are the public health consultant, expert in charge of a program, right? Mayor of a city requests you to do that. Who will be the stakeholders? Childhood obesity. Sonu, what are your suggestions for such a program?
Yeah, ma'am.
Okay. So it's okay. So several if it is a canteen, school canteen, right? That is one stakeholder. Actually, it's only like patchy activities, but then a few schools tried with a healthy plate. When the child brings food, it has to fit in into those areas. There has to be some vegetables like that, and several such activities. So parents are stakeholders, right? If the school canteen is there, that is a stakeholder. If it is for the entire city, all the institutions, companies, business, like shops, bakehouses, all these become stakeholders. Definitely, there is a strong health component also. We have to, give scientific advice and sometimes some clinical intervention as well. Now, schools for health approach, that's again an example from Netherlands. Education, environment. See, in all these, Sonu was about to say something. Jitin is about to say something. Jitin? Several themes are there. So schools can take up any of these themes, like nutrition, exercise and sport, smoking prevention, or prevention of alcohol and drugs, relationships, sexual hygiene, any of these, media literacy, use of mobile phones. So there will be checklists and there will be themes. So schools can select any of these themes, and then they should excel in either one or some of the selected themes. And then they'll apply for the school for health certificates. And then the authorities will give them that certificate. So that improves the label of that school, right? If you are certified, if the school is a certified school for health, has that acknowledgement, recognition, right? That rating of the school goes up. Those are all examples. Actually, the examples we had quoted are from Sweden, Netherlands, etc. Denmark, I think initially I began with some Denmark examples. Incidentally, there is something called solution focused approach, which is not only in Netherlands, but then Dr. Arnold Huber from Netherlands is one person who is going around the world teaching. Actually, we tried this approach in one of our schools in Trivandrum. What you see is the Cotton Hill School. You might identify Dr. Siju, Dr. Matthew, and many others from the Trivandrum Community Medicine Group. So you can also see. So actually, the parents invite us, the PT has suggested for such a class. It's not a collaborative kind of work at the primary level, but since Netherlands examples were there and solution focused approach is one, see, we need community medicine people need some kind of additional competencies to be part of collaborative work. One is that we have to identify and get involved, but in the process, we also need to learn some of the competencies which that particular collaboration needs. See, working with schools, some of the, if it is for stress reduction or, improving the relationship between children, between parents, life skills. So in any of the areas we can, some kind of a capacity building. The last example from the international scene I would like to discuss is from the Swedish family centers. In Kerala, there are family health centers which are moved from the UK model. This is the Swedish family health centers. So there, they bring together under one roof public funded health and social services. And the focus is on child health, women's health. See, there is an open preschool and social services. We also have a social justice department. We have women and child department. We have Anganwadis, which was earlier with the social justice larger umbrella. Now there is a separate women and child department. But the social services, we also have social workers. But the way the social services get delivered in some countries where this sector is very strong is different from what we see in India. There, the here in India, we have the health system where there is a division, and we know one JPH or JHI is responsible for a family, but then it's a very large number compared to the kind of one-to-one intervention, especially social or psychological, the social worker can provide. So there's a single team to promote see family health, safe attachment. See, attachment is another area in child mental health which a lot of advancement happens, lots of intervention should happen. Here we identify these issues at a later age, much later age than ideal time of intervention. And no discussion on collaboration is complete without mentioning about the role of politicians. We have, we work with, administrators, politicians at various levels, starting from grassroots to the district and state. Inherently, the world over, politicians are not hostile to public health because we deal with people, their needs, their interventions. And in health, the stakeholders need not be directly interested in public health. For example, finance, market, insurance, industry, these are all important, rather more powerful stakeholders in public health than, core public health people like us. But even in those countries, there is a consensus. Usually, policymakers and politicians give priority to these kinds of interventions, which do good, general good to people at large. But we have to be with them. We have to. There is some kind of a capacity building knowledge enhancement, skill and competency enhancement for all the other stakeholders also. Okay, there is a public health agency. I just wanted to mention about the public health agency which many countries have. I think some of the Swedish examples could happen also because of the public health agency. Many other countries also have such agencies. Those are all a few examples. We will come to our own examples, but then what do you think are the challenges for these kinds of collaborations? Jitin? Yes.
As we mentioned, politics itself, the stakeholders may be not willing to accept the changes advocated to them.
Okay. Who is not willing to accept? I couldn't get the first part of your statement.
The politicians, the stakeholders, okay. The recipients of the services. So,
okay. Okay. Good. Thank you. Any other challenge? Stakeholders may not be willing to accept the changes. That's one.
Financial changes, constraints.
Okay.
Mostly.
Okay. Very good. For countries like ours, definitely money matters. Jitin, that's a good point. Any other? Have you ever attempted to collaborate? May not be at a PhD level, but collaborating with, it's working together with a common goal. Our department with some other department, our institution with some other institution.
We had in the whole India and Kerala itself, we had as being a private institution, we were called upon by the district administration for COVID-related duties and conferences. That's the collaboration I can think of right now.
Okay. Outbreak containment, epidemic response, right?
Yes.
Okay. Okay, epidemic now, that is the most in thing, right? Epidemic response, lots of collaborations. The way collaborations happen, it's unprecedented, right? So yes. The revenue, the health, the police, every sector, right? So working together, holding hands together. So especially, countries like ours where the resources are so limited, our response was much efficient and effective, and resource we have very limited resources. Still, we could fairly do well compared to those other countries. Actually, that was the point which the Lancet article, I think that was those countries, actually those countries where the primary care and public health which had systems in place. For example, if there is a disconnect between primary, secondary, and tertiary care, someone who is at domiciliary care, home isolation, right? So there has to be a mechanism wherein the person who is on home isolation is monitored, then brought to either the first or second line or the tertiary, the vehicle, lots of, working together happens there. So even in those countries where tertiary care was splendid, the numbers were huge, all facilities were there. There was always a disconnect. So that is really there. I think epidemic response is one. Any other example? Any other challenge? There are several. Okay, thank you, Jitin. So the what we benefit. See, we all have a routine, whether we are a primary health center, medical officer, a JR or a faculty or some other staff in community medicine, or some other clinician, politician, the panchayat, right? We all have our own, core areas to work. So beyond, see, collaboration is always, coming out and thinking out of the box, working together for some other common goal. We are setting the goal, right? and we are finding our partners for collaboration. So beyond material incentives, there has to be some motivation, right? So that is really important. And to begin with, the benefits are usually intangible. For example, you think about a lifestyle intervention, something to reduce, a learning problem in children, a weight reduction program, improve compliance somewhere. The benefits may not be really immediate. The outcome may not be measured, in an immediate period of time. And many of the benefits are intangible. And this kind of motivation or, a drive, it's difficult to foster externally. It has to come from inside. And as human beings and institutions and agencies, we all have a kind of inertia. So coming out of that is really important. And we need to see COVID, there is a sense of purpose. Why do people join hands? Whether it be a community kitchen or, giving a helping hand to someone, health and police working together, right? There is a sense of purpose. Beyond the material incentives, professionals need to believe in the worthiness of the goals of working together. Say in COVID, the numbers come down and we have an end point. There is a goal. And there is something, that perception of, having done well, the intangible measure of staff well-being, and co-benefit to the partners. In working together, it is important. We work with maybe the Trivandrum District Panchayat. We have a role, or maybe we have some other partner. So the PHC has a benefit. The Panchayat also has a benefit. So it has to be clear and explicit. Working together for a common goal. 1, 2, and 3 are the stakeholders. 1, 2, and 3 will get the visibility. If the program succeeds, all the partners have to be acknowledged. See, this kind of understanding is important in working together and collaboration. And mobilizing, I think Jitin mentioned about resources, which is a very important challenge in collaboration. It's not only the money, right? So we have to enable good communication, identify specific, motivated. So to begin with, if you would try to, there are 100, stakeholders. Every stakeholder may not come on board initially. Think of individuals. See, every JPH and JHI and a medical officer in a system, in a primary health center, may not come forward with equal motivation and vigor to start something. But definitely in every institution, there will be proactive individuals, right? Systems or, new movements, new collaborations begin with them, those with motivation. If it works, others will join, right? So especially for new things, the general conventional thinking is that youngsters will be more positive towards beginning new. That is theory. Who are the partners of collaboration in health in the Indian and the Kerala setting? Please volunteer. Someone please volunteer and speak a few words. Who are the partners for collaboration in health?
As you mentioned earlier, the general population, the recipients, the
Residents, yes.
Politicians involved.
Politicians, then Jitin. Gada, who are the important stakeholders in health? In a primary health center, which are the usual institutions or agencies with which we collaborate?
Education.
Education is one. Who is that? You can read actually. Anyone can unmute and speak who that is and what is the context. Ellen, please call out a name.
Ma'am, Dr. Rahul is there.
Rahul. Rahul? Balwantrai Mehta is. Who was he? Anyone? Anyone can speak. Please unmute.
He had a committee, like
Very good.
Balwantrai Mehta committee for
Architecture of
Panchayati Raj institution.
Very good. Excellent. So, Balwantrai Mehta committee recommended the three-tier system. Basically, what was he? He was the second chief minister of an Indian state, Gujarat. So I think he died in a very unfortunate event. Does anyone remember that? Actually, by the shot by the Pakistan Air Force. Actually, the flight that he was traveling was crossing, the allegation was that it was crossing into the Pakistan border. So very unfortunate during the war times. Okay. So that is Balwantrai Mehta, and the Balwantrai Mehta committee was appointed by the government in 1957 to examine the working of the Community Development Program, the CDP, 1952. And it recommended democratic decentralization. And which was the state which first implemented the democratic or, Panchayat Samiti came into being?
Rajasthan.
Very good, Rajasthan. So today the elections are happening at Kottayam, Ernakulam and other districts in Kerala. We have the three-tier system, Gram Panchayat at the village level, Panchayat Samiti at the block level, and the Zilla Parishad at the district level. That is from the Balwantrai Mehta committee. Actually, what is happening today is different from what Balwantrai Mehta, like different in the sense, there is some other breakthrough landmark event that happened in between. What was that? The first elections under Rajasthan Panchayat Samitis, and that was another act, Rajasthan Panchayat Samiti in Zilla Parishad Act 1959. And something else happened in between. The way the elections happen today in Kerala and the functioning happens and the collaboration happens between LSCD and health is based on something else. What is that? It's a very powerful event. There is a legal framework for that. What is that? It's a law. What is that? What am I? See, local government is a term used world over. The United Nations Division of Public Health Administration. See, it's only it means a political subdivision of a nation. It's constituted by law, and it has subnational control of local affairs, power to impose taxes, and it's a local government, right? So what was the breakthrough event that happened? It is a Constitutional Amendment Act, 73rd Amendment, right? So 1992, when Mr. Rajiv Gandhi was the Prime Minister of India, it was actually a breakthrough. See, the Panchayat Raj has a history in India, right? The conventional, or the Gandhi and Grama Swaraj and all, and the Balwantrai Mehta committee recommendations, and then it was the 73rd Amendment, and as part of that, actually the directive principles of state policy, Article 40, lays down that the state shall take steps to organize village panchayats and endow them with powers and authority as may be necessary to enable them function as, governments. And lots of powers were delegated. Resources were mobilized. See, pre-Panchayati Raj years, Kerala is a state where the Panchayati Raj system is most powerful. Kerala is a state where panchayats really play an important role, the collaborative role with the health sector. So prior to that, the fund flow, the budget allocation, if we analyze the way budgetary allocations to departments, individual departments happened, it was totally different. Now the health budget comes to people, or an individual Kerala, citizen of India gets like, I think state to state, the variations are wide. I'm not sure, Ellen, from which all states do we have participants? Ellen, which all states do we have participants?
From Northeast, I don't know particularly which all states. From Rajasthan, even from Srinagar, it's there.
Okay, so the LSCD system and its functioning and their role in collaboration with the health may vary from state to state. It is really powerful in Kerala, and lots of funds from LSCD. In some there was a comprehensive health project scheme wherein there were examples, even 50% of the allocation of the LSCD went for health projects. So the important stakeholders in primary care are the LSCD, police. We have seen there's a section on police and public health in the Oxford textbook of public health, right? The global textbook of public health. So police, a very important stakeholder. As Jitin said, the residents associations, Kudumbashri, and all these agencies where I've just mentioned about fitness, because lots of other agencies are involved: schools, food safety, the water department, local private hospitals, palliative care, several areas of collaboration. So what should we do to improve the collaboration? First with LSCD. See, once the election results are over, some of the members and Panchayat presidents might have worked earlier also, but I'm sure there will be a big number who are new to the system, the local self-government. So a lot of training and the empowerment of LSCD members on public health priorities is really important. Usually curative care, hospitals, it is important that infrastructure gets strengthened, but it is also important that we do not increase the number of people who have diabetes. It's important that they remain non-diabetic at least for one more decade in their life. It will save a lot of money. Their health, that money will be spent for their children's education, other important positive aspects of life. So this communication has to go, and most of the local silver, what you see is a photograph from our urban health center, Pangapara, where Dr. Anupama, the assistant surgeon, plants a tree along with Mr. Vijay Kumar, who was earlier councillor of that Srikaryam ward. He's no more. He was working closely with the primary health center. So you can see the entire team from, I think, our driver, Mr. Hanu, the office staff, Mr. Radhakrishnan, Mr. Parth, and our JHIs, our health inspector, the office superintendent, health supervisor, everyone is there. The staff nurse, the pharmacist, everyone is seen. So naturally, working together with someone who is outside the institution, there has to be a we feel when we collaborate with an agency. So shared ownership and trust about, so it is based on some activity, whether it be school health or, you know, lifestyle promotion. We have 3 or 4 stakeholders working together, and that common goal should have it should be a shared ownership, and there has to be a trust. Like the LSCD person should not feel that, you know, the PHC medical officer has made me work. We make the investment and they get the credit. It should not be. So in the process, in the planning, in the implementation, in the outcome evaluation, sharing the results, and, you know, even getting the credit. Naturally, if it is a good joint initiative by the health and LSCD, there will be visibility, and that visibility also has to be shared. It's important in every collaboration. So goal setting also has to be participatory. There are several methods of participatory goal setting. See, for example, that Amsterdam, I think there are several examples from our own panchayats. When we join together to set the goals, it's a project writing process, right? So health projects are written. So usually from health, the projects, the lead is taken by the health team, but at this stage itself, the LSCD partner has to have an important role in setting the goals, the resources, etc. The 2 words, it's theoretical, horizontal collaboration and vertical. Since the discussion is on collaboration, and if there is an essay for your examination on collaboration, see all these, see everywhere you have a horizontal and vertical, right? We have horizontal programs and vertical programs, horizontal equity and vertical equity. Here also we have horizontal collaboration and vertical collaboration. So horizontal collaboration is at that level. We are connecting with peers and partners, local, regional, and vertical means, you know, there is a system in place wherein at the national policy makers identify the collaboration. For example, tuberculosis control programs. You know, there is a role for important stakeholders. Most of the national programs, they have identified collaborators. The same collaborators will be there at the state, district, and the primary health center level. So I think I am. Is there a comment on anything till now, Ellen?
No, ma'am.
How many minutes more?
Ma'am, the scheduled time is over, but you can continue, ma'am. No problem. You can finish whenever you.
Finish in 5 minutes?
Yeah, sure, ma'am. Take your time, ma'am. No problem.
Okay. So Indian and Kerala setting, there are several areas. I think we have already mentioned about immunization, mother and child health, women's health, healthcare financing, right? In mobilizing resources. And one large area, if you look at the burden to prioritize, naturally, you know, lifestyle disorders is the topmost priority, because in terms of prevalence, that will be the highest burden. That is the MS, metabolic syndrome. If you look at that, adds to everything: metabolic syndrome, obesity, especially the abdominal obesity. Several studies see this is a Pushpagiri article in 2018. This is from Kerala, our own data. See, by criteria, the proportion might vary: 24%, 29, and 33%, going by different criteria of metabolic syndrome. See, it is 1 in 4 to 1 in 3. Such huge is the burden. Definitely, waist circumference among children is a real predictor of future heart disease. Several issues related to food where collaboration will help. This was the replace program of the World Health Organization, which I was just mentioning at the beginning. Review, promote, legislate, assess, create, and enforce. The replace program. So it's easy to mention that the diet has to be healthy, the calories has to be this much. Very difficult to implement. So anyone can be, lots of collaborators. The way we cook our food at home, the way we are trained to, enjoy taste from childhood onwards, lots of changes. So it was no more a health alone area. If you are really targeting at reduction of diabetes, hypertension, heart disease, and metabolic syndrome. See, we need only how many slices of, how much cereals is ideal per day, Ellen? How many ounces or grams of cereals? If you are mentioning slices of bread, that will be a common, easy name. Alan?
I'm 6 years.
If we, yeah, it is 6 slices of, very good, 6 ounces of cereal, or 6, which is equivalent to 6 slices. So we need only that much of, to convert, that into the routine menu or eating what we eat. Lots of collaborative work needs to be done with several stakeholders. And the total reduction of calories is one important. See, for weight reduction, it is calorie reduction. For, preventing cardiac problems, or, strengthening the lots of other areas, it is exercise. So it spans over all non-communicable diseases. 2 interventions we can, that is an ideal. If you go by the calories, it's all American pictures. I started making things and taking photographs, but then I forgot to add those photos in this. So, ഇത്രയൊക്കെ മതി എന്നുള്ളതാണ് diet. അപ്പോൾ ഇതിൽ ഒരുപാട് stakeholders വരണം. Then communicable disease. I think these are all photographs from our primary health centers. Several areas where collaboration works, especially those diseases with stigma. That is Dr. R.K. Shenoy from TD Medical College, Alappuzha. There's a WHO collaborating center for the lymphatic filariasis. Dr. T.K. Suma, the current head of the unit, has received an international award a few days ago. Communicable disease and palliative care. These are all photographs from our own primary health center. Tuberculosis control. That is a counselor, usually, like there will be a gathering, the counselor will come, he'll consume MDA, the PHC, the sub-center wise inauguration is usually by the counselor or the ward member. That is Dr. Hisham. I think he's in Wayanad now. Police is another important stakeholder. That is again school and school health. Tribal health, another very important area where collaboration really works. See, when we talk about collaboration at primary level, the priorities may be national, maybe state, maybe local or regional. In districts where we have tribal or vulnerable, need not be tribal, coastal. So they become priority, and definitely collaboration has to be with related stakeholders. You can see Dr. Joy John of Kuttichal Primary Health Center. He is actually an alumnus of Government Medical College Trivandrum. We went there along with our students. That is the photograph. I just wanted to mention about that is an Egadhyapaga Vidyalayam in the tribal settlement. We can see Prashant and Dr. Siju also. And their an ancient Betsy. Betsy is in Pushpagiri, alle? Alan, Betsy evide?
Yes, ma'am.
Betsy inathundo?
Let
Illa.
me check, ma'am.
Illa. Okay. Okay, so we were working with dengue, and you can see the larvae collected are there in those bottles. They have adults have evolved, and we were trying to identify the species. And this is one, vector trap, gravid adult Aedes vector trap that was locally made based on the model that was sent to us by WHO. So just a few examples. At Primary Health Center at Pangapara, we tried to work with the Kudumbasri. So actually, the other stakeholders or collaborators are very receptive when health personnel approach them, because health is something that is close to the lives of everyone. So the other stakeholders are really receptive if we are able to convince them, but then we couldn't complete it. We had initiated the discussions with the CDS and all, because by the time the COVID came, I think I'll wind up. Who is that? Who is this? Lot of collaboration happened in polio booth. After the election process, booth became very a common term with the polio program. That is Ruxar Khatun, the last polio case in India. And this is, Ellen, who is this? It is something related to politics. Medicine is a social science.
Rodolphe Virchow, ma'am.
It is Virchow. Very good. Medicine is a social science and politics is medicine on a large scale. So at primary healthcare level, this is again a photograph. Your familiar faces must be there. Lot of opportunities for collaboration. We don't usually use the term, may not like to use the term challenges. Of course, challenges is a reality. But instead of that, we would like to take that as an opportunity solutions. These are all more positive terms. So several areas where we can work together. Collaboration is working together with common goals. Each individual, each sector, each institution or agency is so small, helpless, without building a team. What matters is a team. Ultimately, it's true not only in primary level, everywhere it is like that. Actually, the team and collaboration, working together, it enhances our psychological well-being, physical well-being, and socially in moving forward. That is a very important skill as well in public health. Those are 3 photos of the Department of Community Medicine, Trivandrum, with in 3 years. I think the top one is last year, the other one is the middle one was, you can see that Nipah team also. See, it was all a collaborative work, right? Dr. Arun from Manipal, we can see Sarita Madam, the Director of Health Service, Dr. Thomas Matthew, who is then principal and now the JDME, Dr. Gopagumar, the Corporation Health Officer, Dr. Meenakshi, additional DHS, Dr. Vinod, he's actually the Head of Community Medicine at CMC Vellore, Dr. Chandni, Madam is from Calicut, Dr. Anoop from Baby Memorial. We also see the nursing team, which led the infection control at GMC Calicut. So finally, the team matters. Thank you. Thanks once again to Pushpagiri in Community Medicine Department for this opportunity. If there are a few more explanations, queries, or discussions, we can have.
Thank you,
Alan.
ma'am. It was such an informative and interactive session. The session is open for discussion. If anyone wants to ask their questions directly to ma'am, please do so. Ma'am, there's a question that come in the chat box. The question is that the public-private partnership existing like in Ayushman Bharat, is it a collaboration or coordination between public and private sectors? That's the question, ma'am.
Thank you. There is public-private partnership in programs like the tuberculosis control program. Ayushman Bharat, the way it is implemented in different states. Where is the question from? Kerala or outside Kerala?
Ma'am, it's from outside Kerala, from the name.
Okay. Okay. Actually, in Kerala, it is implemented as another umbrella financial protection scheme called CASP, Karunya Arogya Suraksha Pathadi, which has funds from the central government, from the Ayushman Bharat, along with several other schemes of government of Kerala. So it is to improve or increase the coverage. Collaboration, so in the financial risk protection scheme, what happens? Will you unmute and speak? Which state are you from?
I'm from Gujarat, ma'am.
Okay, mouse me. Okay, what exactly is your doubt? Yeah.
Yes, ma'am. I wanted to ask in Ayushman Bharat scheme, like governments are providing, like they're partnering with the private hospitals to provide the private health services to the people below the poverty line. So they are partnering with each other because fund is given by the government and the services are given by the private hospitals. So are they collaborating with each other, or there is
Is there a working together, mouse me? Is someone working together? Are two agencies working together? Government is partnering with a private hospital, right? Is there a common goal? Mosumi.
Yeah.
Yes, there is. What is a common goal?
Health coverage.
Yeah, it is to someone falls sick, they get services from the hospital free of cost, right? So yes, here is there a legal framework? Is there a structure? Is there a framework at all? Is it vertical or horizontal?
Vertical.
It's vertical, right? Is there a legal framework? Is there a common structure?
Yes, ma'am.
Yes, there is a common structure.
MOU.
Yeah, there is a common structure. So it is working together, right? And there is a common goal. So there are several, like many of these campaigns. That's why we said, see, in these vertical collaborations, something that is decided at the central government level, there is a replica of those collaborators at the state level, district level, and it comes down. And there is a framework. It's not that anyone can come inside the scheme, because there is a well thought out framework for that. There is the role of each stakeholder is specified, the outcomes are specified, there is a common goal and objective. Those are all at the larger canvas, but in primary level, when we're talking about collaboration at primary level, we are trying to identify the priorities at the primary level, right? If you are in a primary health center in a hilly area where malnutrition is very prevalent, people have difficulty in access to food. I've removed a lot of slides. Otherwise, we had some data from some tribal settlements. So there, what is a priority, right? People should have access, right? Definitely, there's an education component. There is a making availability component where the public distribution system might come in. Then there might be a vehicle or transport. You saw some slides where people were climbing up. So to make this available there, even if it is there is a shop 3 or 4 kilometers or 5-10 kilometers down the hill, they may not have enough vehicles to carry this up to their residences. So several stakeholders. So it will be having a common goal, reduction of undernutrition among under 5 children or the overall population, and then multiple stakeholders work together. There it is a local one, right? That collaboration need not have a larger vertical framework. It becomes horizontal. Thank you, Mausmi, for that discussion.
Thank you, ma'am.
Which college are you from, Mausmi?
Ma'am, I'm pursuing Masters in Public Health in University of Hyderabad.
Okay. Thank you. Good.
Good afternoon, madam.
Okay. Good afternoon.
First of all, thank you for that excellent class. I just have one doubt. Unlike our curative aspect, preventive aspect is something that does not have the benefits are not measurable, unlike the curative aspect. So you told that there are various stakeholders in our primary healthcare setup. So if we are not able to convince them the measurable aspects, how will be they interested in it, especially when in case of private public partnership? How can we convince those stakeholders, especially in the preventive aspect, when it comes to preventive aspect?
Okay, please introduce yourself. I can't.
My name is Dr. Rahul S. Pillai. I'm from Pushpagiri Medical College.
Okay, thank you, Rahul. What exactly is the kind of intervention Rahul thinks about? Prevention health.
We actually we went for many we went for many programs and camps from here, and actually in those camps, unlike the curative aspects, most all these preventive aspects were not exactly measurable. They were not exactly measurable. So the main the main idea for all those camps was just advertising. So apart from that, is there anything that we can convince these people, these stakeholders, about the preventive aspects, so that we can get equal importance just as curative aspect?
Okay, that's an excellent question, Rahul. Actually, we need to frame objectives for the kind of collaboration. For example, Pushpagiri Community Medicine is working with Thiruvalla. Thiruvalla, is it a municipality?
Yes, ma'am.
Yes.
Yes, ma'am.
Thiruvalla municipality. It may be one ward of the municipality, or a few wards where the hospital is located, or it can be the entire municipality of that Thiruvalla municipality, the entire population. And we have a preventive program. Let it be a school. Actually, to quote an example, we were working with Trivandrum District Panchayat for there's something called a Shishu Sauhrada Jilla, child-friendly district initiative. It was, I mean, just before, just after the launch, actually, the COVID started. So if the institution department works with Thiruvalla municipality, it's good to have a written project on that with the objectives, with the role of community medicine. It's not an one-time camp. It is it may be a one-year project, and where the faculty or postgraduates or undergraduates from the department would go involved in health education with a content that is like, we have to work more on that. There is a module on that. How many sessions, how many trainings, how are you going to evaluate? See, it becomes, when it comes becomes a project, there has to be a mechanism to improve the outcome. If it is a health education, the results may not be shown within 6 months or 1 year, but then there has to be intermediate measures. It may be awareness, it may be, see, it is easy to show difference even in for health education or dietary interventions. If you have a group of people who are diabetic, it is easy. See, the clinical department, endocrinology or general medicine, has a program to treat. See, within the same group, the same persons can have a non-pharmacological intervention with diet and exercise. The outcome measure can be HbA1c itself, or some objective measure, or it can be weight reduction, something that can be measured. So it is, but in totally primordial or primary prevention, it may be level of awareness, the level of compliance, the proportion of people whose obesity has come down. See, in the group where, positive, the level of physical activity has gone up from, you can measure in meds, or a number of hours or days a week, from this to that. So some objective measurements. So it's important that we have a framework, and we have clearly stated what is the role of each stakeholder. What is the role of the Department of Community Medicine? What is the role of some other, if you have some other department from the institution itself, they are the second stakeholder, like endocrinology. Maybe the biochemistry or some other department I'm not talking about research alone. It can be a research project as well. It can be a service project. See, the effectiveness of the intervention can be done as a research mode itself. I'm not sure, Rahul, are you a faculty or a postgraduate? If you are there for only for a short period of time, it can be 1 year or a brief
I'm a
period.
final-year postgraduate.
Yeah. So any time is okay. Any time period is okay. Okay, Rahul, thank you. Actually, the opportunities are so wide. Community medicine as a specialty has gained attention, not only because of COVID. It has to have much more attention because we have to reduce the number of people who are going to need dialysis. The projections are, from maybe now, if 20,000 or 25,000 patients have the facilities to do it daily, the projected that it will come to many lakhs in the coming years. We have to reduce the numbers. So the opportunity, the prospect, the space for community medicine and public health is really enormous. And we have to build our space as well. It's for the community. It's for both of us. It's for the community, and that is for public health. It's both the science and art. That's why we said, when you have such a project, it's good to have some baseline data on the population. If it is the patient is diabetic, at present, what is a control rate? You say that the control rate is only, actually our government data from NCD clinics shows that the actual good control rate is so less for hypertension, diabetes, etc., especially in some areas. So there is a lot of scope for working together.
Yes, ma'am. Thank you, ma'am. I think there's no more questions. Is there any more questions? Okay, I think there's no more questions. Thank you, ma'am. Thank you for taking your time from your very busy schedule and joining us today. We greatly enjoyed hearing you speak and give you viewpoints on that subject. Thank you very much.
Thank you, Ellen. Thank you, everyone.
And thank you, participants, for joining us today. We hope you found all the sessions informative and beneficial. We would love to hear from you, so please do fill the feedback forms. We look forward to interacting with you again. Thank you once again, and we wish you all a wonderful evening ahead.